Hi, Pallavi.
Hi, ma'am.
I think we should start our session. We are already running late by 30 minutes. So without much ado, I'd like to introduce our first speaker. Our keynote address would be by Dr. Robert Goldberg, who is ophthalmic plastic and reconstructive surgeon at UCLA, has more than 200 publications, and has been in the editorial board member for several prominent ophthalmic and plastic surgery journals. He has been recognized as Super Doctors by Southern California Group in 2022 and Top Doctors in Los Angeles Magazine in 2021. He has multiple awards to his credit. And sharing the keynote lecture along with him is Dr. Pallavi Singh, who is orbit and oculoplastic surgeon currently practicing in Ahmedabad, Gujarat. She has done her MD from RP Center AIMS, followed by her senior residency in the subspecialty. She was then selected as a global fellow for 16-month surgical fellowship in orbital and oculofacial plastic surgery under the mentorship of Dr. Goldberg at UCLA. She has more than 30 publications and has presented in various national and international forums and has received several awards. So, Dr. Pallavi, you might share the video or the...
We have a pre-recorded video.
It's 8 o'clock.
Good evening, everyone. It gives me great pleasure to introduce the keynote speaker for this session, my mentor and really, really close to my heart, Dr. Robert Goldberg. I don't think he needs any introduction, so I'm going to dive straight in. We're going to talk about the functional applications of fillers and neurotoxins. I'm Pallavi Singh. I'm an oculoplastic surgeon practicing out of Ahmedabad. So I'm going to talk about functional uses of neurotoxin first, but before that, I'm just going to talk about a few basic principles that we need to keep in mind, whether we are using neurotoxin for cosmetic or functional purposes. The first thing we need to understand is that neurotoxin, as the name suggests, affects the neuromuscular junction. So it acts on the muscle. So we need to know that it addresses animation. So we have, whenever we think about eliminating dynamic lines or dynamic wrinkles, that is when we think about this toxin and not static wrinkles and folds. And so it's important whenever we talk about the use of neurotoxin that you want to customize the injection pattern. Now we do have the same set of muscles, but the strength of the muscles and the width of the muscles differs from person to person. You know, men will tend to have stronger muscles, wider muscles. So it's important to customize our injection pattern in that sense. You can see on the left that the orbicularis is more widespread, and on the right, it's just around the lateral canthal angle. So depending on how wide the muscle is, we want to customize our injection pattern to be able to get the best possible result. We need to know that whenever we use neurotoxin, it's very important to preoperatively get an idea of what the muscles look like dynamically. And it's important to, you know, see the animation of the face, like I said earlier. And I think it's important to steer clear of the whole, product insert mindset that we have that you want to inject spots. I think that's just, most of the training programs that, what do you think about that, Dr. Goldberg?
Pallavi, I'm so glad that you're teaching that and that you understand those concepts, because everyone has different muscular anatomy. And so injecting, the eyebrow or an X or a spot on the face, it doesn't make sense. You have to study each patient, understand where their individual muscles are, which of course requires understanding what each muscle does. And then when you inject specifically into the muscle.
And of course, you want to check the results in 2 weeks, tweak if needed, add a couple of units here or there, depending on how everything's acting up. I'm going to give a quick overview of what the functional uses of neurotoxins are. Blepharospasm, this was what originally botulinum toxin was sort of devised for. And I think this is essentially where most of the principles that we talk about become very important, depending on whether the eyelids are involved, whether half the face is involved. I think it's always helpful to either see an episode in person or to have the patient give you a video to be able to understand what exactly is, the involvement of the muscles and, inject accordingly. And I think there's, Dr. Goldberg, what do you think? I don't think there's any amount of units that we can, you can customize the pattern, but do you have any tips that you would want to give for blepharospasm?
I think like everything in medicine, Pallavi, you start with the least amount of medicine and build up as you need to. So often I'll start with 20 or 30 units, total around the eyes. And again, we inject the muscles, not the spots. And so it always annoys me if I go to someone's office and they just have a picture of a face. I've watched your practice. You have a picture of the muscles and you just indicate how much you've put into each muscle. So perhaps 20 units in the glabellar muscles, 5 to 10 units on each side. That's a good start for blepharospasm. Then, as you say, you can see the patient back in 2 weeks. If it's an inadequate effect, you can increase it the next session. But I find many patients are controlled for many years with 20 to 30 units. On the other hand, some patients need as much as 100 units.
Talking about strabismus, again, one of the original uses of botulinum toxin, especially important in infants and pediatric patients, and very useful in patients who've had multiple surgeries where we don't have any muscles left to operate on. I think the most important thing that we need to sort of keep in mind when it comes to using Botox or botulinum toxin for strabismus is that we don't want this toxin to diffuse into the surrounding muscle. So you want to make sure that you have a high concentration of the drug. And instead of using 2.5 cc's to dilute the drug, like we use for cosmetic Botox, I think I would use about a cc. So you have a really high concentration. And you can use either an open or a closed technique. And just inject directly into the muscle. Again, we don't really have good dose response curves for extraocular muscles. So this is just something you have to sort of learn as you go. Anywhere between 3 to 5 units per muscle is a good starting point, but depending on the age and depending on just how strong the muscle is, the kind of effect you want to customize all of those things. And, you just want to make sure that you tell the patient that it probably will take a couple of times of doing this to be able to get the right amount for that patient. Similarly, one of the other uses that for botulinum toxin that has been described is eyelid retraction. You can inject it directly into the levator muscle, either transcutaneously or transconjunctivally. One of the problems for thyroid eye disease retraction is that it can tend to diffuse to the superior rectus muscle and thus worsen the double vision. And we know that diplopia is just one of the most debilitating sort of features of thyroid eye disease. So I would be wary of that. We tend to use hyaluronic acid gel for these cases in our group. But in cases where you don't have an option, I think it's a great idea. It's a great backup, provided that you counsel the patient and you make sure that you have that discussion with them that the double vision might get worsened over a period of time. One of the newer uses in the past 2 decades, that botulinum has been used for is epiphora, especially used for patients who have increased amount of tearing, who have aberrant reinnervation, crocodile tears, or just functional causes where you don't really have a surgical cause for tearing. So I think it's a fantastic drug to use in these cases. Again, we want to use a high concentration because, as we know, the levator runs right through the lacrimal gland. So I think if we inject transconjunctivally, I think we have the advantage of injecting under direct vision. But there's still I would say about a 25% rate of ptosis. I don't know, Dr. Goldberg, what would you say that your rate of ptosis is?
Yeah, that's been my experience. And by the way, Pallavi, the other option is to inject the orbital lobe of the gland through the skin. And I personally tend to do that. But the needle is going to the same place either way. So I'm not sure it really makes any difference, right? You're getting the needle tip in the same spot, whichever direction.
Now, this is one of my favorite uses of botulinum toxin, using it for senile or spastic entropion. This is something we usually see where the preseptal fibers override the pretarsal fibers. As you can see, she's squeezing hard and you can see that there's entropion. So typically for older patients, for patients who are waiting for surgery, or patients who are debilitated and, are on blood thinners, I think just using about 10 units in the lower lid, in the lower orbicularis can really provide a good temporizing measure until surgery. And in some patients, I think maybe this might be the end of the problem as well. Sometimes they just, they get one injection and they keep coming back for injections because it's much easier for them to just have like a 5-minute procedure every 4 months. The last use that I'm going to talk about is a chemical tarsorrhaphy, where we inject a botulinum toxin in the levator to make the lid fall. Again, very useful in old patients, patients who are on blood thinners, or post-op patients where you expect the condition to resolve. You can either do a transcutaneous or a transconjunctival sort of injection. Again, we don't have good dose response curves, so it might be anywhere between 2.5 to 10 units. You might need to alter that. And there's a high risk of, there is a measurable risk of diplopia, but the eye is closed, so I don't think it really poses a big functional problem. It does come with great advantages. There are no scarring of the lid margin, so that is great, especially for cases where you need multiple tarsorrhaphies. The corneal assessment is very easy. You can just lift the eyelid, you can put in the drops, you can assess the cornea, so that whole ordeal when it comes to assessing the cornea in these cases, I think that becomes easier. But for me, the biggest disadvantage is the lag time, because more often than not, whenever we're doing a tarsorrhaphy, we need to do it stat because the cornea is decompensating. And most of the times you don't really have 2 weeks to wait. So I think that would be the biggest disadvantage for me, but it's still a great option in cases where it can be used.
And the other downside is that, you're stuck with it for 3 months. So,
right.
It has, if the cornea gets better, the patient still can't see.
It's a commitment, so you have to commit to it. So I'm going to hand over to Dr. Goldberg to talk about something we love listening to, the uses of hyaluronic acid gel in the eyelid. Dr. Goldberg, please.
Thanks, Pallavi. And all of these uses are off-label, but we have a 20-year experience in these treatments, and I think they're acceptably safe. Let's look at the next slide. So let's start with tight scars and dermal tissue expansion. So here's a patient with congenital ichthyosis. And if you've taken care of these patients, you understand that there's really not any great medical treatment for this. So what we do in these cases is intradermal expansion to try to actually maybe a little tissue effect or stretch the skin. And what I've found is that in many patients, just a half a cc in each eyelid is enough to really expand the skin. Of course, it can be repeated at regular intervals, maybe every 3 months or so. And, for example, in this patient, Paul, if you show the next slide, you'll see that I was able to create an eye that had really bad lag of thalamus to get enough stretch in the skin to have him close his eye. And we saved the cornea on the other side, and much better than surgery. Also, I'm sure, Pallavi, in your practice in India, you see these patients who've had multiple surgeries with a dense scar in the eyelid. Again, I don't think this is a surgical problem. It's just all biology. And so the next slide, you can see just with multiple injections into the scarred plane, we're able to stretch the tissue and give her some cosmetic and functional improvement in a case that I really believe there's no role for surgery. Now, I've used this for congenital malpositions. Keep it going. So patients with congenital retraction like this, look at this is a little preemie. You can see she's in the neonatal ICU. I don't think anyone's thrilled about taking a baby like this to surgery, but her cornea was exposed. So in the ICU, we use hyaluronic acid gel to expand the tight tissue. Next slide. And we're able to protect the cornea. And sometimes, either because the child grows or maybe, Pallavi, you get some permanent tissue expansion, sometimes even for the rest of their life, you can avoid surgery. At least you can delay surgery until they're older. Same thing here with the coloboma or some type of congenital ectropion. You can see the improvement that we've gotten in eyelid closure with a 10-minute procedure in the unit. Now, we talked about lower eyelid retraction a little bit a moment ago. Next slide. But I've thought about this, and I know, Pallavi, you have talked about this a lot also. We used to think of retraction as just a shortening of the middle lamella. Next slide. And I think that's true. There is some length, but I don't think length is the main problem in these multi-operated cases. I think it's volume collapse. And what we can do so we can surgically lengthen the eyelid just with an end glove lysis. And then what I think is left is not a length problem, but a volume problem. We can put in free fat graft or dermis strip graft. Next slide. But the other option is to address that volume defect with hyaluronic acid gel. And we can do that without any surgery at all. Next slide. So here's a difficult case, a patient with a very nice lady with unfortunate necrotizing infection. And you can see all the volume collapse. And by the way, she's skittish. She's had too much surgery already. And I don't think surgery is a great answer because there's this volume collapse. So look at what we've been able to accomplish just with a filler alone to try to replace the volume, I guess, put air in the tire and lift the eyelid. Cosmetic and functional improvement, completely non-surgical. This is a patient 2 weeks after, 1 or 2 weeks after surgery, a nice plastic surgeon. I think this is your case, Pallavi. And he comes in, the surgeon's unhappy, the patient's unhappy. And I think the last thing you want to do is drag them back to surgery. But here, just with the gel, we've been able to protect the conjunctiva, reverse the early situation, reverse some of the psychological fire that's burning. And then look at him 4 weeks later, the eyes quieted down, the chemosis is improved, and he ended up not needing any surgery because we were able to stretch things out. The orbicularis came back. And if you can see the before, and if you click again, Pallavi, it'll run the after. If you look at the bottom right slide, you can see the little tiny bubbles of hyaluronic acid gel. You see them here, all lined up along the retractor plane. So one of the things in my mind that I imagine is maybe the gel also starts to reform some of that bursa between the moving layers of the eyelid. And that may be one of the reasons that we're seeing an improvement in this collapsed eyelid. Next slide. Last, let's talk about upper eyelid retraction. Pallavi already talked a little bit about upper eyelid retraction. And yes, you can use botulinum toxin, but Pallavi, I almost never do it because I'm so worried about two things. First of all, getting double vision, which is catastrophic in these Graves patients. They're already on the verge of double vision. And also, it's just so uncontrolled, right? It's going to be all or none. You can't really titrate the amount. And if you give too much, your next chance to titrate it is 3 months. When a patient has ptosis that they don't like, 3 months seems like 3 years, right? Next slide. So here's a patient, young attorney comes in, early thyroid eye disease. She's miserable. She can't work. She's very self-conscious. Too early for surgery, right? Because she just started with her disease. But here she is in the office after hyaluronic gel injections into the levator plane. Already better. Next slide. Now, the gel will go away over a year. Maybe some of the improvement in the levator function is long-lasting. But even if not, in a year, you have a chance to re-inject or see if maybe the disease is unwinding. But in the acute phase, I think this is a great way to get the patients better. I mean, Pallavi, you did a lot of these injections yourself. What's your impression of the hyaluronic acid gel for eyelid retraction?
I think it's fantastic. And I think it lasts longer than we give it credit for. I mean, I've seen follow-ups come from your clinics that were good for 2 to 3 years. And sometimes that's all they need. They don't really need big orbital decompressions. It's just the retraction that's bothering them. And about 1 cc into the lid, it just does the job for them.
Right. Yeah. Now, sometimes it lasts less time, but you can always add it. Those cases that last 3 years, Pallavi, I wonder if that was just the natural history of the disease. But who cares, right? I mean, you've gotten them through the acute phase. Right. Next slide. So, Pallavi, another really useful trick that it gets me out of trouble is stenting for early overcorrection. So the next slide. I'm sure you've had this happen in your practice. By the way, didn't I teach you that you can never, you remember this case, this was your patient. Do you remember I told you that you can never overcorrect neurofibromatosis?
Yes.
But remember, we overcorrected this young girl. I was just amazed. And she was pretty uncomfortable with overcorrection of the ptosis. Now, you could try to take her back to the OR, but she's a young, skittish girl, and I'd rather not reoperate. It was a bloody surgery. So remember, in the office, we just put a little bit of gel into the levator plane. And this is the technique, just going along the plane of the levator. I usually go through the skin these days. You have to be careful not to go into the globe because it's a pretty narrow spot, but you can find your way into that plane. Next slide. And the nice thing is that we relaxed her right away. And now maybe this will stretch it out because you're doing this in the early phase after surgery, right? So maybe it's like releasing the suture in the levator where it's
exactly.
This is a patient. Do you remember her from Hawaii?
From Hawaii, that's it, from Hawaii, multiple surgeries.
Multi-operated years later. She's really just distressed by this, the retraction and the hollowness. And she has a scar in the posterior lamella. So it's a very difficult case for surgery. Next slide. But we were able to, just in the office, by doing a little bit of injection into the levator plane and a little bit in the superior sulcus, make such a nice improvement. Do you remember how happy she was? She was like tearful.
Happy. She was really happy.
She'd been living with this. And so these are cases that I think are very difficult for surgery, psychologically and technically. Great for the gel. Next slide. And then the last thing I'll mention is that it's useful as like a temporary gold weight. So next slide, you have a patient that comes in with a temporary palsy. This is a good example. I think she had parotid surgery, but they thought that the nerve was going to come back, but she's really uncomfortable from the retraction. You'd rather not have to go to surgery for gold weight, especially if it's going to be temporary, but by putting a cc of hyaluronic acid gel just in the pretarsal plane, you can see that we've allowed just in the office for the eye to close. That'll last for 6 months or a year. And then if the palsy doesn't come back, you have the option of treating it again with the hyaluronic acid or going to a gold weight or some other treatment. Same thing here. Next slide.
So I think it's just basically some of the things that we talked about, like Dr. Goldberg said, you want to treat the muscle, you don't want to treat the skin. So inject the muscles, don't inject the spots, customize the pattern. And especially more important in functional cases, we want to make sure that you're injecting the drug only in the muscle, only in the areas that we want to inject it in. So I think it's really helpful to have a high concentration to prevent the diffusion. What do you have to say about fillers, Dr. J?
Okay, so good. So I think that the most important aspect of the fillers is, I think, the psychological effect and the immediate gratification. Even though it's temporary, it's so useful for eyelid retraction, for tight scars, for dermal scarring, and for temporary gold weight. And it probably has just changed my practice. These patients are often so grateful to avoid surgery. It allows you to get to know the patient, to make a relationship without having to do surgery. Sometimes you can avoid surgery altogether. Sometimes it's a temporary measure until you go to surgery. But it really is a great practice builder. And what you'll find in India is that once people know that you know how to do this, they seek you out, because patients really don't want to have surgery if they can help it. We love doing surgery, but think of yourself as a patient, right? But the patients are so grateful sometimes for a simple option that they can help them to avoid surgery. And you make a lifetime friend and admirer of those patients, and the referring doctors often too.
Thank you so much, Dr. Goldberg, for taking the time for speaking to us about just something which is, I feel, still not well understood. These are newer applications of all of these things that in India, we're just beginning to sort of understand in the past, couple of years. So I think it's fantastic.
Okay, but Pallavi, I'm starting to get old, so I'm giving the ball to you now. It's in your court, and I want you to take this field to the next level. Okay, will you do that? Okay. Good night, everybody.
Good night.